Welcome to AETCM, the emergency medicine channel. Today's our topic of discussion acute pancreatitis from the acute inflammatory conditions. So the outline of our presentation today, anatomical note of pancreas, and then what is mean by acute pancreatitis, what's the pathophysiology and then causes, what are the clinical features and then complication, how we have to diagnose in pre-hospital, means assessment point, assessment note, and then how we are diagnosing in hospital, and then finally management in pre-hospital, in hospital. So before getting into the pancreatitis, some anatomical note regarding the pancreas. So pancreas is a gland. So gland we know that will secrete some substances, right? So gland means that have a secretory functions. So here commonly we will gland means, so we know we have a salivary gland, and then we have a pancreas also one of the gland, and then we have a sweat gland. So those are the various types of gland. Mainly our gland we will divide into exocrine and then endocrine. Okay, exocrine and endocrine. Endocrine means, so that whatever the secretion that is secreting inside the gland, that will directly release into the circulation. Okay, that secretion that directly release into the circulation, that is called the endocrine gland. So exocrine means through the duct. So via the some pathway it will reach out the desired location, that is called the exocrine. So endocrine we know from the pituitary gland, that's a master for all gland, and then we have a thyroid gland, and then we have adrenal gland. Those are the things comes under the endocrine. Exocrine also some of the things are there. So the exocrine endocrine difference, these are the things mainly in exo. That note on pancreas, it have a some special feature, that is the only gland that is present with both exocrine and endocrine. So both function, pancreas only have a both endocrine and then exocrine function. So the endocrine part, so that endocrine part mainly that will secrete the or hormones like insulin and then glucagon, somatostatin. Those are the things taken over by the endocrine part. Exocrine wise mainly are like digestive juices, digestive pancreatic juices that will secreted by the exocrine part. So these are the some thing we have to remember in the pancreas. Okay, so again this image you can see the, this is the part already we discussed, right? This green portion, that is the biliary tract. So the nearby that biliary tract we have a opening of this pancreatic duct. So the remember one thing, so whenever the problem that arising in biliary tract, or whenever the problem is arising in the pancreatitis, the chance of getting the other part also it is higher chance. Means if the cholecystitis or cholithiasis happening means, that is the problem in the biliary tract alone, right? So that can affect the your pancreas also, because both are near opening. So both are near opening, right? So whenever the problem in this area or this area, that will affect the nearby structure also. That is one of the thing we have to keep in mind. And then this is regarding the where it is present. So location wise, posterior abdominal wall level is L1 to lumbar 1 and then lumbar 2 vertebra. The shape of this one is a J or redort shape. Lengthwise it is about 15 to 20 centimeter long, and then broadwise it is about 2.5 to 3.8 centimeter. Weightwise it is about 90 grams. So the parts we have a head, neck, body and tail. Head furtherly divided into, that is the one process is there, that is called the uncinate process. And then coming into blood supply, arterial blood supply by the splenic artery, superior pancreatico-duodenal artery, inferior pancreatico-duodenal artery. So venous, where it is draining means, it is also the same vein, splenic vein, and then superior mesenteric and then portal vein. So finally it leads to the inferior vena cava, thereby it leads to the right atrium. So lymphatics wise, head and neck mainly by the pancreatico-duodenal, body and tail wise the pancreatico-splenic. So these are the anatomical note regarding the pancreas. Coming into acute pancreatitis. So we know itis means inflammation. So the inflammation of the pancreas is known as the pancreatitis inflammation. Mainly, the other important thing we have to remember is that it is limited, that inflammation limited to just alone the pancreas. So it can affect only the pancreas, or it may affect the surrounding tissue. So we told in that first part, it can affect your biliary tract, mean the same time it can affect the other regions also. How it is affecting other regions, we'll see in the pathophysiology. And then it may cause the remote organ system dysfunction also. Most of the cases, acute pancreatitis will be like a mild inflammation. Even with the supportive care, it will resolve. So the mortality wise, less than 1% only noted in a record wise. So pathophysiology, it's I will try to explain in a very simple manner. So remember, pancreas have a two function, we told exocrine and then endocrine, right? So this enzyme mainly by the exocrine. So exocrine we told digestive enzyme, right? So the digestive enzyme, what it will do means, this digestive, the name itself, we have a digestive pancreatic juice, right? So whenever the problem that is arising in the duct, pancreatic duct, either because of any stone or because of the cholithiasis that may obstruct the path, or because of any tumors, external intraluminal pressure, so it will affect the that outflow, pancreatic outflow, that juice outflow, it will affect. So outflow affected means what will happen? It have some digestive action. That enzyme have a digestive action. So whenever that the digestive action, what it will do? It will start a digestive function in the pancreas itself. Actually, that juice, it will secrete in the pancreas, that will carried over through the duct, that will drain into the duodenal part. That in duodenum, that will start that will activate it. Actually, that name is called from trypsinogen, that will secreted by our pancreas. It will reach out our duodenum, then it will convert into protease trypsin. So okay, then only it will start the digestive action. So but if the outflow is obstructed means, then that digestive action, that conversion from trypsinogen to or protease trypsin, that will happen inside the pancreas itself. So inside the pancreas itself, it's happening means, what it will do? It will start the digestive action. So digestive action means it will affect your own pancreatic cell itself. So if it is affecting means, that will cause a injury to your own pancreas. If again injury happens means, the body's protective reflex, that is by the inflammation, will occur. So whenever this digestive action is continuing without any treatment, it is continuing means, what will happen? It will cause a mild perforation to major perforation. So automatically whatever content that is present in the pancreas, that can spill out to the nearby organs. The same digestive action will happen in the other region also. That is why we told it can affect the nearby organ, or remote location also it can affect. This is the simplest form of the pathophysiology. So in this slide we can see some other extra details. So trypsinogen is produced by the in the pancreas, that will secreted into the duodenum, where it is converted into protease trypsin. Protease trypsin, so trypsinogen, these are nothing but these are the digestive enzyme. Mainly the trypsinogen will digest or protein substance. Okay, then if we, as like we told, if any transient blockage is happening means, that trypsinogen will activated inside the pancreatic cells itself. So it will activation continues in an unregulated fashion, and then elimination of activated trypsin is inhibited, resulting in high pancreatic level of activated trypsin, or ultimately it will leads to the other digestive enzyme. It will act, the trypsinogen will activate the other digestive enzyme complements like kinins, and then it leading to the pancreatic autodigestion injury, and then finally inflammation. So the causes wise, the more common that well familiar, the term is eye gets smashed. Eye gets smashed, that most of them we aware about those things. So I means idiopathic, G means gallstone, cholithiasis, E means ethanol, that is our alcohol, T means trauma, and then S means steroid drugs, M means malignancy, and then mumps. Mumps means parotitis, or that swelling of parotid salivary gland, autoimmune disease, and then scorpion sting, hypercalcemia, and then hypertriglyceridemia. There is triglyceridemia, and then ERCP. ERCP means endoscopic retrograde cholanangiopancreatography. So this is one of the endoscopic method. Usually will perform if you want to check for any gallbladder or biliary tract, if you want to analyze, or if you want to check the pancreas, means on the time this ERCP will perform. Actually, ERCP is one of the diagnostic procedure for our pancreatitis. So, if any breach in that sterility, or if any while doing a procedure, if any obstruction happen, means that leads to the pancreatitis. And then drugs wise, most commonly you can remember the diuretic drugs like frusemide, and then frusemide is one of the common drug, and then or thiazides, hydrochlorothiazide, chlorothiazides, that is also one of the cause. And then AC inhibitor, Brill category, captopril, enalapril, that is also can cause the or pancreatitis. And then signs and symptoms, mainly the person will present with a severe abdominal pain because of that autodigestion. Mainly the location wise upper quadrant and then mid epigastrium. The nature of the pain will be like a severe deep piercing and then continuous or steady in nature. There won't be a decrease or increase in the pain. The intensity of the pain will be like a constant steady pain. Nausea, vomiting, fever, hypotension. Hypotension, when it will occur, means if the person develop any septic shock or sepsis or any hemorrhagic related, means ultimately the person will develop into the hypotension. And then muscle spasm in the extremities also one of the clinical features. Tachycardia, jaundice, bowel sound wise it may be decreased or absent in nature. Shock may be due to hemorrhage we told, or else shock, hemorrhage, and then septic shock also it can occur. And then Gray Turner syndrome, Cullen signs also one of the signs we can notify in the pancreatitis. Gray Turners means that will be a blackish discoloration in the flank region. Cullen signs mainly will occur in the around the umbilicus, periumbilical area. So complications in a pancreatitis, infection is one of the complications, pseudocyst, and then diabetes. Because of that there will be a problem in the endocrine function, so there will be a problem in the insulin secretion. So because of that reason it can lead to the diabetics. And then pancreatic abscess, respiratory problems, and then malnutrition, pulmonary emboli, disseminated intravascular coagulation. Here the most important life threat is acute pulmonary emboli is a acute life threatening condition that we have to remember. Remaining things are respiratory problems, so that remote location also it can affect, we told, right? And then disseminated intravascular coagulation, these are the some common complications. So how we can the assessment point in the pre-hospital, and then how we have to diagnose in the in-hospital region. So mainly this criteria for the in-hospital. So that in-hospital criteria, we have a 3 criteria. If the person, if you want to tell the person have acute pancreatitis, means the person have to fulfill at least 2 of this 3. First thing is a clinical presentation consistent with the acute pancreatitis. Second thing, that serum amylase lipase level should be more than a normal. That's more than 3 times from the normal. That is called the that we can tell as the pancreatitis. More and then imaging studies also we can go for. Here we have to acute pancreatitis, we can go with an ERCP, and then ultrasonography, transabdominal ultrasonography, MRI, CT also we have to go for. So in this 3, at least the person have to fulfill 2, means then we can tell as acute pancreatitis. So as like we told, amylase lipase level we can check in this 3 times higher than the normal, that is the normal pancreatic level. Moreover, compare with your amylase lipase have a more accuracy with the amylase level. Compare with an amylase, lipase have a more accuracy in the pancreatitis. Why? Means amylase easily excreted through our urine, so easily it will excrete it. And then lipase also will excrete, but it will get reabsorbed. Okay, because of that the lipase will have a long standing. So the elevation level will be like a long standing. After 8 to 14 days only it will start to downtrending, or it will start to fall. That's so up to this state the lipase will be in a higher level. So the lipase also, that's why we told the lipase have a more accuracy. One more thing is amylase we have in our saliva also, so that will mismatch our thing. So that is why better we can go with an lipase level. So urinary amylase level also we can check, because we told amylase easily that will excreted through our urine. So to check that amylase level, you can go with an urinary amylase, blood glucose, CBC, LFT, serum calcium level, serum triglyceride level. So both elevated state, serum hypercalcemia also one of the cause we told, right? And then imaging ways we can go with an ERCP, CT abdomen, abdominal ultrasonography, endoscopic ultrasonography. So management finally, how we have to manage in a pre-hospital. Remember, pain we have to manage first. So the pain means, so based on that level of the person's level of pain, mild or moderate or severe. So we told in on presentation we described the WHO pain ladder pattern and all we discussed. So based on that, if the person is falling under the mild or moderate or severe means, based on that we can treat with an NSAID or opiates we can go. And then if the person have a pain because of any muscle spasm means, then we can go with an any antispasmodic dicyclomine, that also we can try for. And then second thing is a prevention of shock. So in pre-hospital, mainly prevention of shock, that mainly will happen in the in-hospital. If the person in the shock while treating, while in transit or while in pre-hospital, if the person in shock means, then we can go with an aggressive fluid management, or we can go with an some other. If the person is not revert back, or the person is, the hypotension is again refractory to the fluid therapy means, then we automatically we can go with a vasopressor, that is our noradrenaline and then adrenaline vasopressin, that we can go for. And then prevention of shock mainly will have focus in the in-hospital region. So that we have to find out the cause for the shock, either that is because of septic or that is because of hemorrhagic. So based on that our strategy will differ. So septic shock means we will depend upon the antibiotic therapy. If it is because of hemorrhagic shock means, then we will go with some other fluid management and then replacement of that lost volume, right? That is the thing. And then third one is a reduction of pancreatic secretion. So while receiving in our pre-hospital region itself, we have to keep the person in the NPO. So thereby we can reduce the pancreatic secretion, or else we have to ask the person to avoid some other things like alcohol, those other things we have to ask the person to avoid. That is for the reduction of the pancreatic secretion. So again, if any gastric content, if the person have some time before or while you are picking, or if you are going to receive person, but sometimes before only he or she had something means, then you can put trials tube and then you can aspirate the content. So those are the things also we can, thereby also you can reduce the pancreatic secretion. And then fourth one is a control of fluid and then electrolyte imbalances. So that is why that electrolyte imbalance, you have to think about the calcium level. So you should not administer more and more calcium, means ringer lactate and then some other cabulates. So we have to control administration. And then prevention or treatment of the infection, that is also mainly in the in-hospital. So on pre-hospital we are mainly focusing on symptomatic thing. First one, pain relief management, and then if any muscle spasm is there means antispasmodic, and then we have to keep the person in the NPO. These are the things we have to follow in the pre-hospital. So the same thing only if the hypovolemia, we have to give the administration of fluids, nasogastric tube, and then decrease stimulation by avoidance of alcohol, and then keep the patient in the NPO. Oxygen therapy, that ABCDE always you have to remember. So here we told only for the pancreatitis. So the remaining things, airway, breathing, circulation, disability, exposure, that is constant for the every management part. And then antispasmodic, NTG also you can use. So finally, so these are the things also, whichever gastric emergency we are going to handle, this the thing we have to keep in mind. First thing, we have to reduce the gastric acid secretion. Second thing, antiemetic. So this is the two common drugs always you have to remember in whichever gastric emergency you are going to. That is because of any gastroesophageal varices or peptic ulcer or upper GI, lower GI bit, whichever thing. If you are handling the gastric emergency, keep in mind PAN or your some other antacids, H2 receptor blockers, or you have to remember other second thing you have to remember is the antiemetic. Okay, So these are the two common drugs you have to remember. And then calcium, if the person, some rather time the person in a hypocalcemia means, then you can go with an calcium. So that calcium gluconate 10 percentage you can inject into the 500 ml NS, and then you can administer over 5 hours. So that is for the calcium correction. And then diet wise, low fat and then high protein diet, small frequent feeding we can start. Pancreatic enzyme supplementation with meals. So supplementation we have in market, we have in a capsule or tablet format, that is also we can do the supplementation. So surgical, when we will go for the surgical management means, if the person developing pancreatic abscess or severe peritonitis cases, acute pseudocyst means, then we will go with an manage with a surgical approach. So do your best. Shalom.